I have the honor of introducing our next speaker, Jamal McClendon from Mayo in Scottsdale and Phoenix and Scottsdale, who will be discussing part 2 of treatment of high-grade spondylolisthesis in the pediatric patient.
Great. Thanks, Dr. Metz. I'd like to thank UCSF. I'd like to thank our course directors for selecting me again to present to you all today. Thanks, Lee and Kyle as well. And thanks for all of you all being here. Put together a great presentation and also a great forum for us to discuss and share and exchange our ideas in addition to develop some friendships. So I appreciate it. These are my disclosures. So we're going to talk a little bit about high-grade spondylolisthesis. Slides kind of changed here. Do you mind bringing up my previous my newer presentation? Sorry. All right, thank you. Part 2. I'd like to highlight our Great. I'd like to highlight our Phoenix Children's group. We have a great group and always welcome to invite you all to be with us and join us. We have a great group of neurosurgeons and orthopedic surgeons working together. So spondylolisthesis is described with the Greek word spondyle meaning vertebra, olisthesis meaning slipping or dislocation, with a prevalence of 4 to 6 degrees percent in childhood and 5 to 10% in adults. We had a very nice discussion that Dr. George gave in his part 1, really highlighting the nomenclature in addition to treatment modalities and furthermore, a lot of the history as it relates to treatment of high-grade spondylolisthesis. We'll start with this initial patient, a 15-year-old female who presented with kind of a grade 2 / a grade 3 when during flexion and extension. It's not uncommon for these patients, particularly at this particular grade, to come in with without any major symptoms. They may be seeing us, particularly may be related to some asymmetry in their hips, and they received an evaluation, and ultimately they have an imaging modality or imaging finding that leads them to come see us in the office. A couple of things that we can pick up based on Dr. George's presentation yesterday as it relates to the lysis within the pars itself, some of the dysplastic natures of the sacrum being some doming, in addition to the aspect of L5, where there is a index where the posterior aspect of L5 has a different length than the anterior aspect of L5, described as a lumbar index, which is different from the one of the adults that we'd seen in the office that had a pretty significant slip of the vertebra. And she presented with some nerve-related tension signs, excuse me, in addition to some tight hamstrings, and furthermore, some lumbar radiculopathy. The treatment of these 2 individuals would be very different from an asymptomatic patient versus a symptomatic patient. Obviously, the degrees are quite is more severe. And then how we define and treat this, I'd like to discuss a little bit with you regarding my thoughts and my considerations, ultimately leading to an instrumented fusion where we expand the disc space into the vertebral body without a significant reduction, but evidence of a decompression. So for high-grade spondylolisthesis, patients can present in multiple different ways, whether it's pain located specifically in the back or any aspects of radiations of pain. And the disability that individuals may experience or feel may not be the disability where we need to fill out any paperwork per se, but essentially how they walk or how they crouch their gait, or that they can't actually stand up straight, or they're having some form of functional limitations that they're not able to play their sport. Neurologic dysfunction, whether it's weakness or evidence of any other issue or challenge as it relates to their ambulation. And then further discussions relaying into their alignment and whether they're balanced or not, particularly when they stand up. So getting into a little bit more detail, again, the back pain or the gluteal-based pain with certain activities that may be challenging or quite difficult for them to extend their back, or if they have any radiations of pain going down into the feet, some of the neurologic symptoms, and then their appearance, whether they have a difficulty walking or they feel like they're leaning forward when they're walking. There was a study looking at the natural history of folks who were essentially 500 first graders, and the examination, the evaluation was looking at a whole class of individuals just to see what's the actual prevalence. And so of those 500 first graders, 30 of which had evidence of spondylolisthesis, which gave us a prevalence of about 6%. The unilateral bilateral pars defect in these asymptomatic children were assessed using plain film radiographs, and the unilateral the unilateral defects were found not to actually have a significant progression after they followed these patients or these individuals over the years throughout their grade school and into their adult lives. But they did notice that the bilateral defects in the pars tend to have some form of a progression as to the net that's related to the general population. They also defined some of the criteria for classification and looking at the lumbar indices, the slip angle, and then furthermore, the actual classification of the actual slip progression over time. But when we think about classifying spondylolisthesis, it's important for us to actually get the appropriate measurements so that we can actually, one, communicate to other individuals, but then also look to see what is actually going to, what's most likely to progress in time, so that if we were to able to allow for a definitive treatment, can we actually improve upon that to actually prevent the progression? The initial classification systems, initially starting with Wiltse, really allowed us to actually have a frame of reference to talk based upon the cause of the listhesis. The type 1 being more of a dysplastic or developmental in the Wiltse, where there is a congenital aspect of the posterior elements of L5 or even S1. The type 2, which either had a stress lysis in the 2A, a pars elongation in the 2B, or even a pars fracture in the 2C. And then there's the degenerative, the traumatic, and the pathologic. The Marchetti and the Bortolozzi started to introduce the idea of having dysplastic elements and really distinguished itself from the Wiltse classification because grading the high and the low grade dysplasia actually allowed for us to communicate who is going to be likely to have a progression and also to define what that actually looks like radiographically. And it also helped distinguish between the developmental and the acquired, still taking into consideration of the traumatic post-surgical and the pathologic and the degenerative populations. But bear in mind, it's still very important for us as we consider what it means to actually allow for a correction if these slips are going to progress in time, what that actually means as far as what we can look forward to as far as defining an improvement in their with the treatment modality. So for the individuals who had a low-grade slip, we have to, in looking at the pelvic parameters, the low PI and the low sacral slope we described as it was initially described as a nutcracker type phenomenon, where individuals over time would hyperextend and they'd develop potentially a lysis within the actual pars itself. The individual with the high PI and the high sacral slope, the downward forces created more of a shear type phenomenon. This is originally defined by the McTiang literature, actually looking at patients with low-grade spondylolisthesis. For patients with the high-grade spondylolisthesis, really looking at seeing if the pelvis was balanced or unbalanced helped to form a reference point for individuals needing or at least allowing for a treatment for these particular slip types. Further literature really looked at risk factors for progression, whether it was female gender, the age at presentation, the severity of slip at the presentation, the high bony dysplasia, and the increased slip angle. And based on that and having the idea of seeing who is going to progress, thinking about what are actual, what can we do or what can we see on these radiographs which can define who is going to be likely to progress to then have a discussion for us as far as the treatment guidelines. The Spinal Deformity Study Group created a classification of 6 different spondylolisthesis types, which takes into consideration the grade of slip, the pelvic incidence, in addition to the spinal pelvic alignment. For the low grade, again, for the low grade slips, the type 1 and type 2, the shear, the nutcracker was initially defined for the low PI and the low sacral slope folks. For the individuals that have the low pelvic tilt and the high pelvic tilt, particularly depending on the pelvis being balanced or unbalanced, particularly for the high grade slips, we then have to figure out how much is the patient compensating, and even if they are compensating, do they still have an unbalanced pelvis? that created a classification system that we now have here, which includes 6 different types. I think what's important and things that I think about myself is that if the spondylolisthesis, the patients have an unbalanced spine, and if the patient is compensating, there's going to be a lot of work that's going to be necessary as far as treatment for those individuals with an unbalanced spine and a high pelvic tilt, ultimately to be able to allow for an overall improved alignment. There's a cluster analysis that actually looked for and defined what that unbalanced pelvis and the sacral pelvis of the sacrum and the pelvis look like to further give us a classification system to actually look to see if it was appropriate or not appropriate to do a significant correction for these individuals. And that 6 classification system was further modified based on the dysplasia to actually give a classification of 8 different types that can be used to create a system for treatment. So my own personal ideas as far as treatment is that, usually for the high grade slips for the individuals, non-operative treatment is relatively uncommon. The goals for me is to try to relieve their pain, try to prevent any neurologic deterioration, and hopefully to not cause any neurologic issues or problems in the process of trying to treat their slip. Ultimately, to get a solid arthrodesis is very critical. I want to restore their sagittal alignment if it's at all possible, and also to improve their overall appearance, which is secondary or maybe even tertiary. There was an important study that was done which actually evaluated patients over a pretty significant time point in which uninstrumented fusions were utilized, using autologous bone graft products, in the absence of any instrumentation. It highlighted both the posterior lateral fusion and anterior fusion and the circumferential fusion. What was interesting in this is that even though they reported very, very high fusion rates, 86%, 100%, and 96%, there was glossed over the actual neurologic deficits that patients had after these particular operations. Additionally, if you look a little bit more in the details, their slip angle, the individuals that actually progressed their slip angles was quite impressive over that time period. In addition, there wasn't a substantial amount of improvement of their overall lumbosacral angle. So though individuals can have these sort of treatment types and the uninstrumented fusions, it really didn't improve their slip angles a whole lot, and there was quite a bit amount of progression even despite a fusion. They actually described this as more of a settling phenomenon, even though the patients were quote unquote adequately fused. Another particular type of treatment modality, as Dr. George alluded to, was the more distraction-based phenomenon, where individuals would be prepared in surgery. Distraction would be performed at the sacral ala, whether it's up to the inferior aspect of the lamina of L1, and then either autologous bone graft products were performed either anteriorly or posteriorly, in this particular case in the anterior plane, to allow for an actually improvement for their fusion. I think that there's a lot of advantages in performing distraction, as was highlighted both in this particular study by Dr. DeWald, in addition to the Bowman technique, where there is distraction elements that were performed. But this one really allowed for a solid-based anterior arthrodesis in the absence of of a significant reduction. The reduction was actually performed with the patients on the table and really getting a solid arthrodesis and fusion both posterior laterally and also through the dowel-based techniques through a fibular strut. Highlighting, in addition to a fibular-based strut, actually instrumentation or utilizing instrumentation to both fixate the sacrum and the L5 vertebra without a substantial reduction, or what was actually achieved by positioning patients on the table or even in situ distracting rod, I think offers a lot of advantages over a substantial amount of reduction forces. So this is a case example of one of my case is a patient presented with grade 4 or even a grade 5 spondyloptosis, had significant progression over time, in which she actually presented to us. She very uniquely wasn't having a substantial amount of symptoms over this particular, when she had seen us in the office. She had perhaps maybe some numbness in the distal toes. So taking into consideration a lot of the literature that had been discussed, not really focusing on a substantial amount of reduction forces for her, but using some of the similar techniques of actually placing instrumentation through the sacrum, maybe a small window of a decompression, but really stabilizing the patient in that position, I think were ideal and satisfactory and harmonious for us. Even before surgery, she didn't really have an unbalanced pelvis. You can see that she has a very low sacral slope, but a high pelvic tilt. So taking into consideration from the previous discussions on the nomenclature by Mac Tiong, trying to figure out what's the best strategy for her was all part of the decision-making process. Dr. George spent a lot of great time discussing on whether you should decompress and whether you should reduce. I think it's a lot. It depends on the actual symptoms of the patient, quite frankly. There was an article looking at 42 patients without decompression that had an instrumented fusion posteriorly versus a combined fusion. The patients initially had 100% back pain and half had about radiculopathy. They were able to achieve a substantial amount of improvement, but the neurologic deficits were pretty pronounced without an obvious decompression, even with the patients with radiculopathy. This paper was criticized quite a bit in that the patients, about 6 of the 44 patients needed to undergo a reoperation. And so perhaps maybe the consideration of decompressing the neural elements is very valid for the aspects of postoperative neurologic deficits are not inconsequential. But I think really one of the hallmarks is should you actually need to reduce some of these patients? Now, certainly there had been some discussion regarding it perhaps maybe decreases the neurologic deficits where you can actually take the L5 nerve root and change the morphology to a more normal, looking nerve root with a reduction. Perhaps if you need to actually increase the opportunity for you to have a solid fusion mass along your transverse processes, there's a need to reduce or even to reduce the slip angle. One of the things that I've struggled with from a technical perspective and trying to reduce is that when you are grabbing a hold of L5 or even L4 and trying to reduce the L5 vertebra, there's not a whole lot of distance with your tulip heads to allow for a substantial amount of reduction in addition to actually lordosis creation through that particular area. This is a nice study also looking at fusion, decompression fusion, and then also comparing individuals with reduction in fusion. And even the individuals who had a decompression in fusion really also had a pretty substantial high rate of neurologic issues and neurologic challenges even after the operation. So sometimes even in the best hands and even while decompressing, I think these postoperative neurologic challenges or even delayed neurologic challenges are not inconsequential. Now, a lot of the literature actually looking at what the L5 nerve root is doing from an EMG perspective intraoperatively bears a lot of weight, particularly to hopes to actually decreasing the incidence of a postoperative neurologic deficit. Asking the question of whether you should consider an anterior support or having anterior column support. This was looked at in comparing individuals who had an L4 to the sacrum fusion, an instrumented fusion with decompression, and then also adding an interbody through an ALIF approach or through a posterior lateral approach. Certainly from a pseudoarthrosis perspective, adding that anterior column support substantially decreases pseudoarthrosis, but we also need to bear in mind that in order to actually achieve or get around, even from a posterior lateral approach to place that interbody, we lose some of our bony surface area to allow for an arthrodesis and fusion posterior laterally. And should you fixate to the pelvis? This was looked at through a porcine model, which looked at axial range of rotation, flexion and extension, in addition to lateral bending. And we found that by placing the iliac fixation or elements of iliac fixation, that substantially decreases the range of motion, protecting the sacral screws. So even though we take care of patients in their pediatric and the adult and the young adults, we also must make in light to consider the cone of economy and what it means for balance and harmony, and also the ideas of our Russley classification, so that when we are treating and taking care of these patients, that we're not creating or not going from an unbalanced spine or an unbalanced sacropelvic alignment to continuing that so they can have continued problems in the future. So I take into consideration of all the similar adult conversations that I have in my mind when I'm taking care of the pediatric patients in addition to the young adults, so that I can create harmony and alignment. And I also look at the Hills and Kelly classification to make sure that I'm achieving my T4 and L1 pelvic axis. Pelvic alignment. So everything comes into consideration even when we're taking care of lumbosacral pathology. This is a case example of a 16-year-old that I had followed in time. She had a kind of a grade 1, grade 2 slip, and she had some minimal symptoms at the time, so we continued to follow her. And then when she was 24, she then started having some additional dysplasia of her sacrum and pelvis, and the lysis worsened, and her flexion extension kind of changed. And so I was trying to think of different opportunities for allow for an improvement. But what I noticed is that her lumbosacral angle didn't really substantially change, particularly, and she had quite a bit of reduction, even though she had like a grade 3 or even a grade 4 slip on her imaging. So for this one, actually, I kind of violated a lot of my rules, and because when I looked at her overall harmony and alignment, I think that, if I just stabilize her position where it is and get a good solid arthrodesis infusion, I think that she'll be okay long term. And she's 3 years out with this minimally invasive, decompression. I really just kind of stabilized where she was at, and then did not use any sacrum and did not use any iliac fixation on this one. But I think with a lot of the soft tissue that she had preserved, I felt that this was okay, and I was able to put some bone graft products posterior laterally as well. This is a final case example, just looking at a young lady that had a young girl that had a pretty substantial progression over her time. And one of my partners did an instrument infusion where they fixated across the sacrum through the L5. Unfortunately, the implants of the instrumentation were quite prominent. And because of that, the instrumentation was removed. When the instrumentation was removed, unfortunately, she had the nuclear medicine bone scan highlighting a pretty substantial increased radioactive, the radio tracer uptake at the lumbosacral junction, in addition to a further increased slip angle. More dysplasia was happening and progressing across the sacrum and the pelvis. So I didn't feel like it was necessary for me to actually allow for a reduction. I ultimately just decided to try to see if I can change ever so slightly the slip angle for her. But she had a significant amount of lordosis that I didn't want to ultimately take away from her. And so I was able to achieve a nice result, and she's doing quite well several years later here. Great. And in the interest of time, thank you.
Very nice overview. And,
Appreciate it.
Thanks for sharing. Just a couple of questions. We really, Mac Chung was Hubert Labelle's resident, and most of the work is done by Hubert Labelle. And the classification, I think, is a really excellent classification to use as a kind of a way to look at it. So the 1, 2, and 3 are low grade, and I think the main issue is foraminal stenosis of the L5 nerve root, which is often from disc or slip and things like that. So that's usually what drives a lot of their L5 symptoms, as opposed to a central stenosis. And then, on his, so 1, 2, and 3 are the low grade with different PIs, and then 4 would be a balanced spine or balanced pelvis with a high grade, and then a 5 would be a balanced spine, but high PT. And then the 6 are going to be high PT and unbalanced spine with a high SVA. And the 6, I think nobody argues should be reduced. And then the reduction is either angulation or translation, right? Or both. Yeah. And often for the 5, we do try to get at least some angular correction in to get some of the lumbosacral lordosis and things like that. So I think I just don't know if that classification is getting enough. It was out since 2011. You put it up very nicely there. I think it really sets a good algorithm for people, for type 4s with no increase in the pelvic tilt, no increase in the SVA. Those are very good in situ fusions you don't need to go crazy on. The 5, we try to get some angular correction, and the 6, we do a little bit more aggressive. And I think they need to be differentiated because a 4 and a 6 shouldn't be treated the same way.
Very, very nicely articulated. I completely agree. Thank you.
Jamal, that was a really terrific overview. I think too often we see our developmental listhesis cases combined with our acquired and even outcomes. I think that spinal listhesis is really we're clumping very discrete things together. And I think that dysplastic olisthesis is a very distinct phenomenon compared to our acquired olisthesis. And to that end, can you talk a little bit about, you had a couple of examples where you went transosseous and where you maybe did more of an in situ, and certainly Paus's work would support that. At the same time, can you talk a little bit about the technique if you're going to try and get a reduction of the lumbar sacral kyphosis? What's your technique there? And do you have any pearls for how to really get that lumbar sacral kyphosis reduced?
Yeah, thank you. So it's quite tricky and quite challenging because when I looked at the technical aspects, because oftentimes the pedicles at L5 are quite dysplastic and quite small. And so the angulation of the trajectory, whether you're using image guidance or navigation or even freehand to actually place the implants. And so the implant is out of the way of the L5 nerve root. And then so that you can have enough distance from your S1 screws so that if you are to get posterior translation, it's very, very tricky because oftentimes your tulip heads are already kissing each other so as to get lordosis through that particular region. You're actually not going to be able to, and you actually maybe while you're doing your posterior translation, actually creating more kyphosis. And so if I were to denote that, then I wouldn't try to allow for any posterior translation and allow myself to just fixate in that plane, just see if I can get a little bit of lordosis without the posterior translation, or maybe be able to take some aspects of the posterior aspect of the sacrum so that the L5 nerve root has a little bit additional room to breathe within the frame and to allow for some lordosis, all bearing in mind that I need to get about 35 to 40 degrees of lordosis between L4 and S1. So all the adult things that we think about also bear in mind in the kids as well. And so it's quite challenging. So I just have to see how much room I have to create some lordosis if I'm actually doing some posterior translation for that reduction.
Yeah, and I'll just add to that, I think the really key part to sparing the L5 nerve root is a lot of work in that interbody space, including the sacral dome osteotomy. Okay. So I'm really shortening between L5 and S1, and my L5 becomes so mobile before I try any kind of reduction. And I think that really makes a big difference, is being really, really proactive about mobilizing, just having L5 almost wobbly. Okay. and shortening the sacral dome, I think, protects the L5 roots.
Thank you.
Yeah, I usually get the lordosis through the disc space, because I don't think you can do it with the screws up. Yeah. Especially in the high grade ones, the L5 pedicle is often very dysplastic, and it's hard to get a home run on that screw. So if you take the paddle inside the disc space and you lever 5 up, and that gives you a ton of lordosis, and then I lock in the rod, and then I put my interbody after.
Oh, that's smart.
And you get an incredible amount of lordosis that way.
Oh, that's smart. Thank you.
I do exactly the same thing that Dr. Lewis described as cantilevering through the disc space. And in my practice, the use of expandable cages, PLIF style, so bilateral expandable cages, have been very helpful. That's and nice. There are cages that can get about 20 degrees of lordosis. And, restoring the L5 S1 lordosis seems, the kids are not affected as much when they're younger because they lordose in the upper lumbar, but they become very problematic when they're adults. And, having a practice where I see the kids and the adults, once they get into their 40s and 50s, those are the ones that usually need longer fusions because they degenerate all those upper discs when the lumbar lordosis is compensating over the upper lumbar. So we work pretty hard to get that, and that's been pretty successful, and low threshold to go to L4 and pelvis to get that correction.
Great.
Yeah, awesome talk. Just to piggyback on that, for those class 6 with the really high PI, 80, 90, and you're doing a sacral dome osteotomy, one thing I've sort of struggled or just sort of a question about is your mindset of, are you going to push and cantilever the pelvis down, or are you going to reduce and pull the spine into the pelvis? So just kind of your thoughts or techniques on that.
Yeah, I think it's a lot of it has to do with the strength of my confidence in my fixation at L5, in addition to the actual rod type that I'm using. So historically, I've just tried to really pull up L5, but I haven't used the thought purely on pushing down on S1 yet. That's a good thought. Thank you.
And one thing that comes to mind, I think, as Yashara mentioned, as these patients get older, their ability to compensate for segmental malalignment, compensate above their fusion for segmental malalignment, I think decreases. And so I guess a question for Dr. Lewis is, are we looking at, when we look at these patients with balanced versus unbalanced spine, are we just looking at patients in a different part of their, of different ages or a different part of their disease process, where they can go from a balanced to an unbalanced spine with the same lumbosacral anatomy?
It's not to, all you have to do is look on the 3 foot, whether they have thoracic kyphosis and lumbolordosis. And as soon as they start compensating, you're going to start seeing thoracic lordosis and you're going to see the compensation through the lumbar. And so when I think they mean by balanced spine is you just don't see any of that compensation. So you see on your 3 foot, you're just going to see a normal looking spine. As soon as you start seeing that compensation, that global compensation, now you have an unbalanced spine to go with an unbalanced high pelvic tilt.
Yeah.
Just one other question.
Please.
I saw you go to L3 a fair bit. Why? Tell me about why you would do L3.
So that last case in the L3 is that the patient had a previous, the previous construct was up to L3. And so I stuck with that. That was from just a previous partner did that particular approach. That's all.
I think I like, if you have a very vertical sacrum, I think pushing the sacrum down is a really excellent technique. It doesn't work if the sacrum is horizontal, obviously.
Okay.
And it's much easier to do if you have 2 fixation points. So I usually use an iliac wing screw with a connector, so I don't ruin the SI joint for these young kids. And then if you go S1 to that connector, then you can actually you combine bringing the 5 up at the same time as bringing the sacrum down. So I think to answer your question, I usually do a combination of both on a vertical sacrum.
Awesome. Thank you.
Steve, based on that, what are you looking for in neuromonitoring in changes? What modalities are you looking for to look at the L5? And what do you ask your monitoring guy to do differently when you're doing a spondy reduction?
First, number 1 is put a needle in EHL. Okay. So I don't need a lot of the other needles. So I usually do an S1. So he'll have a needle in S1, tiband, and gastrocs at a minimum. And then what we do differently is, as discussed yesterday, direct nerve stim. And so if you put the probe on, then I usually do the Gill Lamy, check the nerve. And this way you can check your S1s and your L5s on both sides. They should be to at least under 3 milliamps. So and then every time I do a step, I check again the signal, and then you can see if your conduction goes down. If you go to 8 or 10, you know that the nerve is a little bit unhappy with you. And I don't think EMG, SSEP is, usually an SSEP is put in the gastrocs. So it doesn't give you, it gives you an S1. SSEP is really good for core because, it doesn't matter which nerve you hit, but otherwise you'd have to put you can either put a posterior tibial sensory or a perineal sensory. So those are the 2 for your S1. So you may want to put it in the L5, just that covers L5 a bit if you want your SSEP. But I think the direct nerve stim is the number 1. And I think you should practice that even on a decompressions with your neuromonitoring team, so when you really need it, you can be able to, if they're giving you 10, you should stimulate it too on a normal nerve and get signals. So if you do that on your regular ones, you're going to pick it up.
Smart. Thank you.